Hey everybody, welcome back for another episode of Physio Show. Today we are exploring the latest evidence-based guidelines for the management of osteoarthritis. These guidelines were published just last year by the National Institute of Healthcare Excellence, and they're packed full of needs to knows for both patients and providers. Did you know that it can take up to 17 years for new evidence to be implemented into practice on a wide scale? This incredibly slow rate of change in medical practice is why it's important for both providers and patients to stay current with the newest evidence. And the recommendations in this paper are a great example of that, with some of the recommendations directly challenging many commonly held beliefs and treatments that are still utilized today. So some of the information that I'm going to cover may go against what you've experienced or heard from doctors or friends. That's why it's my goal to help you stay ahead of the curve so that you can make the most informed decisions about managing arthritis. We will cover everything from the most and least effective treatments, what surgeries to avoid, medication considerations, and how to know when you need a total joint replacement. I've also included a link to the document and a great infographic in the description, so feel free to check them out for more detail. X-rays are amongst the most overprescribed diagnostic tools in medical practice. And the truth is, they don't really add much value when it comes to managing arthritis. A thorough history and physical examination is all that is needed to effectively make a clinical diagnosis and treat arthritis. The guidelines suggest that individuals who are over the age of 45 experience joint pain related to activity and experience morning stiffness that lasts no longer than 30 minutes can be confidently diagnosed with osteoarthritis. However, morning stiffness is not necessarily required to make a diagnosis in all cases. So if it looks like a duck, quacks like a duck, and moves like a duck, let's just call it a duck and not decide to zap it with radiation just to be sure. And you may be wondering, wouldn't it be beneficial to have an X-ray so you know how severe the arthritis is? Well, research is showing that severity ratings using imaging are quite limited and do not always reflect how the patient feels or functions, meaning they can be bone on bone and walking around just fine, while another person could have minimal arthritis and be in extreme discomfort. This is because the image is just one small piece of a very multifactorial picture that is arthritis. There are even some studies demonstrating diagnostic imaging may have a potential negative impact on outcomes. Those who receive diagnostic tests, such as X-rays, have been shown to experience worse outcomes compared to those who do not receive imaging. This is attributed to people often feeling less well when told of the imaging findings, even if the findings have no direct impact on their pain or physical health. It's like finding your first gray hair. You're the same person as you were yesterday, but it can be quite traumatic. So not only does imaging not add value in patient care, it may also even lead to psychological harm. Now, when it comes to ordering X-rays, the guidelines suggest doing so only when atypical features are present. These atypical features could indicate an alternative or competing diagnosis, or even a more serious condition. It is suggested a person with suspected arthritis receive X-rays in the presence of a history of recent trauma, prolonged morning joint-related stiffness that lasts longer than 30 minutes, rapid worsening of symptoms or deformity, develops a hot or swollen joint, or presents with suspicion of infection or cancer. Otherwise, hold on imaging and start treatment. It's almost a guarantee that if you're experiencing pain, you'll walk out of the doctor's office with some form of medication. While we have been making great efforts to address the overprescription of opioids, it's important to note that even the non-addictive pain medications come with their own set of side effects. And because arthritis is a chronic condition, those who are prescribed pain medications often end up taking them for an extended period of time, increasing the likelihood of side effects being experienced. One of the most common types of medications prescribed for managing arthritis are non-steroidal anti-inflammatories, or NSAIDs. While they can provide relief, it's important to understand that these medications are not meant to treat the condition itself. Instead, their role is to help manage symptoms and should be used as a short-term solution. The guidelines suggest that medications prescribed for arthritis should be used at the lowest effective dose for the shortest duration possible, and suggest they be combined with other non-pharmacological pain relief strategies to support tolerance to exercise. The guidelines also suggest starting off with a topical anti-inflammatory cream, rather than jumping straight to oral medications. Topical creams have been shown to have fewer side effects. If the topical medication isn't effective in managing pain, then oral medication can be considered. But here's the key. Medication is just one aspect of managing arthritis. The goal is not to completely eliminate pain altogether, or rely solely on medications as a standalone treatment. Instead, the aim is to open a window of opportunity where a more active rehabilitation approach can be better tolerated. So it's essential to keep in mind that medication should be used as needed, alongside other non-pharmacological treatments. They play a supportive role in managing arthritis and allow patients to engage in exercise and therapies that can make a significant difference in their overall well-being. Just as important as highlighting treatments that are beneficial is highlighting those that are not, because it is common for treatments that lack efficacy to continue to be provided despite evidence against their use. This is partly due to the delay in change in practice patterns, as we mentioned earlier, but also due to the financial incentives that many treatments come with. Viscosupplementation injections are one of these types of treatments, which comes with a nice price point for providers and is quick and easy to perform in the office. These are the injections that are marketed as ways to restore lubrication to arthritic joints. But there is plenty of evidence showing there is no indication of its effectiveness to reduce pain, improve quality of life, or enhance physical function for individuals with arthritis. The guidelines strongly discourage the use of viscosupplementation injections when managing this condition. And these injections are quite costly and are hardly ever covered by insurance. So unless you want to contribute to your doctor's vacation fund, it's probably best to steer clear of viscosupplementation. Corticosteroid injections are another common method of managing arthritis pain, but unlike viscosupplementation, there is evidence showing the benefits of corticosteroid injections to provide short-term benefits of reducing pain and improving function. However, it's important to note that these benefits typically don't last beyond 3 months. And that's okay, because just like pain medications, it provides a window of opportunity to take a more active approach. But here's the issue. Many people often opt for these injections as a quick fix to manage pain, but then skip out on active management. This results in many receiving injections every few months, which is essentially just putting a band-aid on a much bigger issue that inevitably gets worse over time and ultimately leads to joint replacement. The guidelines suggest considering cortisone injections only if other pain management medications, such as NSAIDs, are ineffective. And even then, cortisone injections should only be used as a means to improve tolerance for a more active, exercise-based approach. In other words, injections should never be used as a standalone treatment. Now let's talk about the most important thing you can do to manage arthritis: sitting on your couch and doing nothing. Just kidding. It's exercise, of course. But you might be thinking, why should I exercise if it hurts just to walk up the stairs? Well, this is because arthritis pain is often intensified due to stiffness of the joint and weakness. Those with arthritis have also been shown to have altered pain processing as well, a phenomenon called central sensitization. Central sensitization refers to the process that occurs in the central nervous system, particularly in the spinal cord and brain, where the nervous system becomes hypersensitive to movement, pressure, and temperature, causing an exaggerated response to pain, or even the perception of pain in the absence of tissue damage. And this is where exercise comes in, with proven benefits for improving mobility and strength, while also reducing sensitivity to movement. And it might hurt at first, but over time, with consistent exercise, symptoms will likely improve as the body becomes more tolerant to activity. The guidelines recommend developing a tailored exercise program that suits individual needs. The focus should be on improving strength, flexibility, and cardiovascular fitness. When it comes to managing arthritis, physical therapists are the experts. They can help you create exercise plans that address many movement dysfunctions you may have. It's important to stick to the plan in the long run for lasting relief, so try to fit regular and consistent exercise into your daily schedule. In addition to exercise, the guidelines suggest combining manual therapy treatment. This can include techniques like soft tissue and joint mobilization and manipulations. However, the guidelines highlight that manual therapy should always be combined with exercises to get the most out of it. So steer clear of providers who rely solely on passive treatments. You know who I'm talking about. Some common treatments to be aware of that lack sufficient evidence when managing arthritis include acupuncture, dry needling, and electrotherapies listed here. This is not to say that some of these treatments can't be utilized, but they definitely should not be the primary treatment approach. Instead, focus should be on taking an active exercise approach in combination with manual therapy. If you have additional time, you can sprinkle in some other treatments as needed. Except for ultrasound. That treatment is worthless. When it comes to managing osteoarthritis, weight loss plays a significant role. After all, joints are crucial for our movement and the distribution of forces in our bodies. So it's not surprising that shedding some pounds can be beneficial. However, most of the research focuses on the benefits of weight loss for knee arthritis specifically. But that doesn't mean you get a free pass if you have arthritis in other parts of your body. That just simply means that there is not enough evidence to make a specific recommendation for arthritis in other joints at this time. Besides reducing pressure through joints, weight loss has several other advantages. It can help in reducing inflammatory factors that cause pain and swelling, while also lower the risk of developing arthritis in other joints in the body. While any amount of weight loss can be helpful, the target goal is to lose about 10% of your body weight. A big take-home point from these guidelines is that weight loss does not appear to have an impact on post-operative outcomes. Even if someone is overweight or obese based on their BMI, the current evidence has found no increase in risk of mortality after surgery. In fact, those who are overweight tend to do just as well as those that are not, experiencing improved health-related quality of life and patient-reported outcome measures. Based on these findings, the guidelines state that weight loss alone should not be a barrier to joint replacement surgery, which goes against the common practice today of requiring many to lose weight prior to surgery. Now, it should be noted that this finding is speaking to just body weight and is not considering other comorbidities. So if you're managing osteoarthritis, weight loss can be beneficial, not only for reducing stress through your joints, but also for its potential anti-inflammatory effects and preventative benefits. And when it comes to surgical options, don't let weight hold you back. The most important thing is to consult with your healthcare provider to determine the best course of care for your specific situation. If a doctor suggests cleaning out your joint as a solution for arthritis, it's time to find a different doctor, because there is no evidence to support the effectiveness of arthroscopic procedures in reducing pain or improving physical function for those with arthritis. In fact, these procedures have risks associated with them, and the studies have been shown that they are no better than sham surgeries. Yes, that's right, no better than doing nothing at all. When it comes to surgical options for arthritis, the gold standard procedure is a total joint replacement. This should be considered if joint symptoms such as pain, stiffness, and deformity significantly impact quality of life, and if non-surgical management strategies have been exhausted. And a few visits to physical therapy doesn't count as exhausting non-surgical options. The guidelines recommend at least 8 to 12 weeks of intensive physical therapy, with focus on high-intensity exercise-based approaches combined with manual therapy and pain management strategies. Using walking aids like walking sticks and canes can be helpful strategies for individuals with lower body arthritis. These aids can provide support, unload painful joints, and improve walking tolerance to promote more physical activity. However, it's important to note that recommendations for their use is based on more expert opinion rather than solid evidence. On the other hand, the guidelines do not recommend the routine use of shoe insoles, braces, tapes, splints, or supports for individuals with arthritis, unless certain conditions are met. These conditions include the presence of joint instability or abnormal joint loading, when therapeutic exercise alone is ineffective or unsuitable without other aids or devices, or when the addition of an aid or device is likely to enhance movement and function. Frankly, I'm not entirely sure why someone would even use these items if not for these specific reasons. But hey, that's what the guidelines suggest. But the big take-home point is that just like medications and steroid injections, these strategies should focus on promoting a more active rehab approach and not used as a standalone. So if you find that walking devices can provide you with necessary support and relief, it's worth giving them a try. Just keep in mind that evidence supporting their use may not be as robust as we would like. But ultimately, it's best to consult with your physical therapist who can assess your individual needs and provide personal recommendations based on your specific situation. And there you have it, the nice guidelines for managing osteoarthritis. I would love to hear your thoughts on these guidelines. Do they match what you have heard or have experienced? Feel free to share your comments below. And if you liked our video and would like to hear more, give us a like and subscribe to the channel to keep up to date on the latest physical therapy research.